Welcome everyone to the Health Enterprises Network Forum. We are very pleased. This is such a good turnout, and so we're very pleased with that. And we're very pleased to have Secretary Friedlander with us, who obviously has captured a lot of this interest. Before I begin, I would like to thank our sponsor, Sakulo Health, for making sure this event could happen. And Tom and Sakulo will address you in a moment and introduce Secretary Friedlander. So again, for everyone who's new to these events, which we have quite a few new people, welcome. We invite your participation and we're happy you're here. Anyone returning, you'll notice we're doing things a little different, although we still are coming from my daughter's bedroom, unfortunately, and not from my office or in person, but welcome. But anyway, our goal at the Health Policy Forum is to establish a working relationship with all of our elected and appointed officials and to be a resource to our community and to them as they consider policy that will impact our health-related business community and health-related economy. Like other aspects of the Health Enterprise Network, our goal is to convene healthcare leaders and to facilitate a dialogue so that we can all work together to champion and foster the growth of our health-related business and health-related economic community. So this is very important. We're excited. Perhaps the virtual meetings have presented a greater opportunity, and we're aware of that. But again, thank you so much. Please visit our website at Health Enterprise Network to learn more about the Health Enterprise Network. We really invite you. We want you to be involved, so that we can all make our healthcare ecosystem better here in Louisville and the surrounding area. Couple housekeeping items. First of all, if you are not on mute, please put it on mute so that we don't hear background noise as Secretary Friedlander speaks. And we are pleased, again, that so many of you have joined us. So we ask that you submit your questions through a chat feature. We hope to have a very interactive experience, and we'll do our best to get to your questions. So again, put those into the chat feature and ask questions. We'll collect them and then we'll present them to Secretary Friedlander. So without any further time by me, here's Tom McMahon, who is the go-to market lead for Sakulo Health. Tom?
Thanks, Dan. Good morning, everybody. It's a beautiful spring day here in Louisville. If you're not here, you're missing out. But if you aren't here, we're also glad to have you. So thanks to everybody for joining. I do want to add my thanks to the Secretary for taking the time to share some of his insights today, and also just to thank him for his significant commitment to public service. I'll share his bio in a minute, but it's impressive and it's important. Also want to thank our team at Health Enterprises Network and at GLI who helps us with these events. So Ben and McCarran and Sally and Alana have been very helpful, and none of this stuff goes off as smoothly without all their good work. I also see Tally Russell on the line and appreciate her helping us make a connection with the Secretary. So it's always nice to have some support from my friends at Humana. Even though I have left them, I still like them. So and then I'd be remiss if I didn't say thanks to our board. We have a board of about 50 people who really represent the broad array of healthcare enterprises here in the area, and are awesome to serve with. And I enjoy it every day, and glad to keep doing it. So as I thought about our event for this morning, a couple ideas came to mind. I thought I'd share those because, it wouldn't be a good event if you didn't have a couple talking heads saying whatever they feel like saying while you're waiting to hear the person you wanted to hear. But I did join a new company. It's called Circulo Health. Apologies for the difficult pronunciation, but I joined the company because I really saw a confluence of two things that I haven't seen in a long time. So one is the tremendous need for change in healthcare. Spending just goes up and up and up. It doesn't go down. And really an interest in adopting technologies that make a difference. So things like artificial intelligence, which is what our company does, and telehealth is a simple example. That just there's some unfortunate reasons why we are where we are, but there have been some silver linings, and so I'm excited to see that. And as I got excited about that sector and dug in and learned more about those companies, I kind of surprised myself with how many there really are in what you might call digital health or insure tech or other things, and specifically how many are here in Louisville. So something we're going to be working on this year at Health Enterprises Network, sooner rather than later, is to help everyone understand a little bit more about the technologies that are out there, but also who's doing it. And because we have some significant companies that were started here that are still here and are really making a difference. So more to come on all that. So that brings me back to the discussion for today. So Medicaid, it's a big deal. Only 75 million people in the US use Medicaid for their healthcare services. And the populations inside it that's a broad array of populations, and is not what people think it is. It's people like you and me who, if you file for unemployment in Kentucky, you get Medicaid. If you happen to have a certain income level, you can qualify, but you also have people with lots of different conditions that qualify, and it's a tremendously important area for our country. And I'm super excited to hear the Secretary talk a little bit about what's going on in our Medicaid program and beyond. He oversees more than just that, but certainly there's a lot. So I think the thing I challenge folks to focus on in listening to the Secretary and just thinking about technology and healthcare in Louisville is are you looking at technology? Are you looking for it? How do you do that? Are you building technology assets in some way? And are you finding ways to safely and reliably deploy them? And I think these are important questions. I bet you are. And we'd love to know more about who's doing that at your company, and we want to promote that. So let me switch over to introducing the Secretary. So Secretary Friedlander is the Secretary for the Cabinet for Health and Family Services, appointed by Governor Andy Beshear in December of 2019. That marks, or this year marks 35 years in public service, most of them in the Cabinet for Health and Family Services, but not all. He's also served in other roles of the cabinet, of course, as a deputy secretary under Governor Steve Beshear. And he did a small project while he was there, which was to implement the Affordable Care Act. So we do appreciate that. There's a long bio, very interesting background. I know we're eager to listen to the secretary, so I'll just say that, he's held a number of positions at the cabinet, and also, I think really interestingly, served as the Chief Resilience Officer for the city of Louisville as well. So again, appreciate your service, Secretary Friedlander. So with that, I'll hand it to you. Thank you.
Thank you, Tom. Appreciate the opportunity to talk today. Very good to see a lot of my friends. I enjoyed working for the city of Louisville, but many of you I've worked with over the years. I've worked for a few of you. So it's good to see everybody on the line today. Many of you then know the Cabinet for Health and Family Services, but I'm going to give you a little update as to where we are. The Cabinet employs more than 8,000 people across the Commonwealth. We have offices in every county. Some of that is a slightly changed way that we do things now. There are over 1.6 million people who receive their healthcare coverage through Medicaid. So that's a little better than 1 in every 3 Kentuckians who receive their coverage through Medicaid. We also then have over 600,000 individuals who receive SNAP. That's what's known as food stamps. We have many folks who receive childcare. We have served over 2 million meals through our senior meals program, through our aging and independent living programs. We, of course, have seen an increase, particularly as you look at our Medicaid reimbursement on services, particularly in the area of behavioral health and substance use, looking to continue some of that. So it's a broad swath of programs that go across the Commonwealth. Oh, and public health. You all know Dr. Stack. He has beautiful hair like me. And he has been so important in our response to COVID. And when you look at Kentucky compared to the nation, compared to our region, we really have been punching above our weight in terms of vaccinations, testing, low positivity rate, all the things that you really do want to see in a public health response. It is unfortunate, as you all as health providers know, there's been some unfortunate pieces of a divide on what is science and what is not, but we're very fortunate to have a governor who believes in science and has been leading us through this, all of us together, to use his quote a little bit. So it's been a very important time. I would say my being named Secretary of the Health and Family Services Cabinet I don't think I could have worse timing, but it's certainly been a critical time for us to be able to work together. There's an experienced team there, and I hope you all feel at least comforted that you do have an experienced team leading us through this time. And I'm very pleased with the things we've been able to do in terms of innovation within the Medicaid program. We have put in place something called presumptive eligibility at a level that is unusual for a state. We still may be the only state providing presumptive eligibility at the state level as opposed to an individual hospital or provider level. With that, we have over 100,000 people who are receiving their coverage through this presumptive eligibility program, where we really have a short form Medicaid, simplified Medicaid application that we have been taking. We are clearly, now that we have an open federal healthcare exchange, we are going to try to transition as many of those folks over to the exchanges as we can, or get those folks who are fully eligible for Medicaid enrolled in the program. And we've been working through that with many of our partners. But in terms of our response to the pandemic, I want to thank you all. It's been our partnership, not only with some of our normal suspects, right, the local health departments and the FQHCs, but really, I see Nancy Galvani on the line. I would be remiss if I didn't thank her and the Hospital Association for your great partnership with us as we have moved through this pandemic. The same is true of some of the long-term care associations, as well as individual hospitals. Norton's has been a great partner with us. University of Louisville and University of Kentucky have been great partners with us. We need to continue those, build upon those partnerships to make sure as we come out of this pandemic, and I'll talk a little more about that in a moment, that we're moving the health needle in Kentucky. It seems to me just a shame that we have 1 in 3 Kentuckians receiving their coverage through Medicaid. We have an $18 billion cabinet, and we still struggle to move the health needle. We still say, thank God for Mississippi, Alabama, West Virginia. I know they probably don't want to hear that, but that is, we need to do better and we need to be better. And that is then what our goals are. To that end, as I was working with the city of Louisville for a few years, and again, honored to serve in the Fisher administration, really came to the point of realizing that there's some things that hadn't been happening at the cabinet that we really needed to elevate. So we talk in the cabinet, and some of this is borrowed from the mayor, but we talk in the cabinet about helping individuals and communities live to their full human potential. You may have heard the mayor say some of that, but we wanted to translate that to the cabinet. So that's really the goal of what we're trying to do with all our programs. And to do that, we've talked about 5 pillars. The 5th, of course, being operational excellence, which of course we all strive for. But then 4 pillars that we're working under, and all of our programs need to fit into. The first one is an equity pillar, particularly focusing on racial equity, and then looking at equity in general. In this country, often it is important for us to lead and understand around issues of race, but then how they translate to urban versus rural, and all the other pieces that come in with barriers to access, and really helping people move forward, again, to reach that full human potential. The second pillar, you heard, I was Chief Resilience Officer for the city, but the second pillar is about resilience, right? And it's about resilience to trauma. And we see that all the time. We have child protective services and adult protective services, an important part of the mission of the cabinet. And so the folks that we serve often have gone through trauma. The workers at the Cabinet for Health and Family Services are often exposed to what is called secondary trauma. It was one of my great regrets when I left the cabinet at the end of the second Bashir administration, that we hadn't done enough to address that within the workforce. So that resilience to trauma, because we always have some sort of shock or stress in our lives, and supporting that from a behavioral health perspective is a very important piece and one of our central pillars. The third pillar, and I'm going to dwell on this and come back to this, is this structural economic support. And I've alluded to it. When you have an $18 billion cabinet, when you have the SNAP program, when you have the WIC program, when you have meals, when you have all these different programs that are providing economic support to individuals, how do we translate that and work together to talk about that on what that means on a county level? And we've been working on data around that. And then, of course, obviously, health and wellness. How do we move the needle on health and wellness in terms of, and really it's diabetes rates, our cancer rates, our obesity rates, I will take that on myself, smoking rates, and then just general days of good behavioral health. How do we move forward with that, with having the levers that we all have together? So I want to drop back because I think this is an important piece. On the structural economic support pillar, we have looked at what does it mean to have, for instance, SNAP. Millions of dollars go into a small county that then support the grocers in that county. It's not just the individual who receives those benefits. It is then on a small margin business like groceries. What does that mean when you have millions of dollars that go in? We talk about those services to individuals, but we don't talk enough about the economic impact of those programs in the local communities. WIC, Women, Infants, and Children. It's a nutrition program for new mothers and children and infants. Those programs, they've done their studies, and they think that for each dollar that goes into a community, it generates $9 of economic activity. So these programs make a huge difference in our local communities. And I haven't even talked about Medicaid. You all as healthcare providers know, without Medicaid, I think our entire healthcare system would collapse. So with that undergirding, we have been able to build significant programs across the Commonwealth. For every, that really it's almost, when you consider Medicaid expansion, for every 20 cents Kentucky spends, we get 80 cents back from the federal government. That, 4-to-1 is a pretty good ratio, and an intelligent way to bring additional federal dollars to the state. And we do try to maximize that federal dollar, but while we do that, we need to work on how we maximize that healthcare impact. And that's where we will continue to be in dialogue with you all. The Hospital Association, we just implemented a program which will really help bring rates and I think align us together to make sure that the support that we're giving, particularly coming out of a pandemic, is sufficient to build on what should be successes. You all, I'm sure, have been interested in following some of the court cases around the managed care organizations and the bid processes. The most recent ruling asking us to rebid the MCOs. It will be the second time now. If those court decisions hold up throughout the system, I will tell you I look forward to doing that. I think being able to turn the RFP process, we did that very quickly in the beginning of the administration, but to have a more thoughtful process about doing that, I'm actually looking forward to that, although it's probably why I don't have any hair, because much of it is pulled out. So that's an important piece moving forward, but our managed care organizations, our partners, helping get us to that 2.5 million that the governor has established for the number of folks he wants to get vaccinated. It's the ground game now. It's you all. It's your individual reach to the patients you serve or the individuals that you talk to about how incredibly effective the vaccines are, how incredibly safe they are, and that this is something that helps us get back to, I don't want to say normal. I want to say get back to hopefully a place where we're better. Because through this pandemic, there are lots of things that I think we've learned. One is we can work differently than we ever thought. These virtual interactions actually work pretty well. I have probably of the 8,000 workers at the cabinet, 90% are working from home. And the interesting thing is the cabinet is working much more efficiently than it ever has. I'll give you a brief example. In February, we had our call line. We were struggling to answer 4,000 calls a day, struggling. We were having abandonment rates at 30%. Wait times were 10 and 12 minutes. We then, between March and April, everybody went home. And today we answer 10,000 calls a day with ease, with maybe a 5% abandonment rate. The call wait times at its longest is about a minute, maybe 2 minutes. We didn't do much different, few changes, but really it's just that we're more efficient and effective from home. We polled the folks who work at the cabinet, and 80% feel better working from home and think that that's a better model. So how do we support that? How do we make those changes? And I think we've all learned from that in many different ways. And like I say, this is an example of that. And then what I also hope that we learn, and I will close with this, is that through a pandemic, through a communicable disease, I hope what we've learned that any time something impacts one of us in our communities, and when I was with Louisville, I was working a lot with the homeless population, but anything that impacts one person in a community really does impact us all. And so we need to think about, from my resilience perspective and resilience lens, when you have a community, it's that weakest part of the community that's most vulnerable where the chain breaks, where your resilience breaks down. And so being able to understand how to strengthen that across all our communities, which I feel like is one of the missions of the cabinet, as well as being in partnership with you all. But that's one of our missions. How do we strengthen all of our communities across the Commonwealth? And that's one thing that we are certainly looking to do. So with that, I'm very happy to take your questions and continue the dialogue.
Thank you, Secretary. Dan, we've got a couple of questions that are popping into the chat box. I'm going to start feeding them to you. So Dan, do you have access to your chat box?
Yeah.
Or would you like me to just start reading the questions?
Well, just go ahead. I mean, I don't think you have to.
Okay. So the first question that came into the chat box, following up to something that you were just talking about, what lessons did you learn from the COVID-19 pandemic that should carry forward to influence healthcare in Kentucky moving forward? So as you mentioned, you know, we've all seen a lot of changes, whether it's more Zoom meetings or what, but specific to healthcare, you know, what have we taken away from this, and how can we continue to improve healthcare now that we've had to speed things up a little bit?
So many things, and what I'll say, I'll start the presumptive eligibility, bringing another 100,000 folks on Medicaid during a pandemic with an enhanced match rate did not break the Medicaid budget. It didn't. So the first thing I learned is that there are ways to bring more people and get more people coverage that don't break the bank. And I think we were able to do that quickly and pivot very quickly within the cabinet. And I think we all learned this. There were things that we were able to do. The cabinet's not known as a nimble organization. I don't think people associate the word nimble and Cabinet for Health and Family Services, but we changed quickly. So what I learned is that we can pivot quickly. We depend more on this environment. We removed a lot of barriers to telehealth, and that has in many cases worked, and folks want to continue with this much more broad and open telehealth network. The General Assembly passed some legislation related to that. We have taken off a lot of prior authorizations and are keeping prior authorizations through our MCOs, keeping prior authorizations off for behavioral health services and substance use services, because we know coming out of a pandemic, we're going to need more of those services. So how do we support that in a way that is fiscally responsible, as well as then responsible to the folks we are trying to serve, those people in need of those services. So learning through that, we are implementing a new pharmacy benefit manager in Medicaid, a single pharmacy benefit manager. We'll see how that goes. I think the other thing we're going to learn is we're going to be studying this pandemic and our response for, I think, the next 20 years. And I believe many PhD papers will be and dissertations will be written on this. And so we will see and learn from, as we go through, what worked and what didn't work. Right now, we're learning about vaccine hesitancy and how much of that is access versus hesitancy. And I think we're going to have to work on how we talk to the folks we're trying to serve, patients, clients, in the healthcare setting, to help them move to more, I don't know how to say it, rational response, a more open response to what should be a healthcare message. The other thing I think we are going to learn is that, I hope we will learn, is that we cannot operate in silos. I know we talk about social determinants of health all the time, to the point where I think folks' ears start to close down. But clearly, the impacts outside of healthcare have a tremendous impact on our healthcare outcomes. So figuring out how to weave these programs together, we have expanded so many programs that provide support for individuals. I mean, to be able to articulate it in a way that it makes sense to the individual and the community. I think those are all pieces that we need to learn together, and our reliance on technology, I think, is only going to accelerate through the next decade. But clearly, that was a trend that was happening anyway, but I believe COVID is going to accelerate that even further. And so it's all those pieces together. Another piece that I will say I think we learned is that, and this is not to be offensive, I think it is challenging to each of us, that the congregate setting, the long-term care setting, we all need to be thinking about how we provide services outside our walls. We saw with devastating clarity that not just Kentucky, but across the world, these congregate settings were vectors. And so how we re-examine and reimagine our long-term care and congregate settings, I think, is going to be a challenge heading into the future. Again, we'll do that in partnership, but I think that is something that we have to admit, and we have to. I started with the cabinet in 1985, and we basically have the same structure that we had then. It's time for us to move forward. So those are all just kind of learnings for now. I'm open to many more learnings as we move forward. One thing, again, that I will credit Mayor Fisher and working in the Fisher administration, it's okay, and I try to make sure that folks in the cabinet feel this way. It's okay for us to try new things and perhaps not be successful, as long as we are learning from them. So I'm sorry, a bit of a long answer, but there's a lot to learn here.
No, that's terrific. That actually opens up a slew of other questions. I'm going to back up for just a second, because you've mentioned it a couple of times. Presumptive eligibility, I think, is a really interesting program that you all put in place. So a couple of questions have come in along those lines. The first one is, how long will presumptive eligibility last for Medicaid enrollees? And then I think a follow-up question is related to that. How are you all actively working to transition people from the Medicaid rolls to the exchange?
So the presumptive eligibility piece will last. So two answers on the larger scale: last through the public health emergency, particularly as it's declared at the federal level, is what we're pinning that to, and that's also pinned to the enhanced FMAP rate for Medicaid. Second, for individuals, people get 2 periods of presumptive eligibility within a year. That was initially about 2 months plus the month that somebody signed up in. So the potential for 3, and then a potential for another 3 through through continuous negotiations with the federal government. It is really now more a 2-month and a 2-month extension. So individuals can have 4 to 6 months, depending, of eligibility for presumptive eligibility within a year. We are actively trying to transition those folks. We're calling. We are working with our MCO partners, particularly United. We based on court rulings, most all of those presumptive eligible individuals were those lives were given to United to bring them up to 100,000 lives. So both United and the cabinet are working and calling those individuals and trying to let them understand how to either become Medicaid eligible or transition to the exchange. The period of presumptive eligibility provides them credible coverage, even though now that the exchange is open, that isn't as big a deal anymore. But they have credible coverage and can transition easily to the exchange. With the expansion under the Biden administration of more affordable policies, we are hoping, and $0 cost policies, we're hoping that that will make that transition easier. But we're doing aggressive outreach to those individuals. Again, the longer answer to that question.
No, I think that is terrific. Another topic that you had ended your last statement with was around kind of technology and innovation. A lot of the members of our organization, and quite frankly in Louisville, as you well know, we operate in what I call the business of healthcare. So we're providers, but we're also the people who are kind of implementing new policies, new procedures, new technology, new innovation. We're running the back offices of many of the provider organizations across the nation. So can you talk a little bit about how the cabinet is or can be working with private organizations to really push for innovation in healthcare? So you mentioned that the cabinet maybe needs a little bit of updating. I think healthcare generally needs a little bit of updating. So what can we do to work together to really push for that innovation and not do everything the way that we did it 15 years ago?
That is an excellent question. First, I'll reflect on the cabinet. Coming back to the cabinet, it was apparent to me that we had a lot of data, and I know this is a cliche, but we had a lot of data and not a lot of information. And I think this will speak to many of your members. We had data on Medicaid members. We have data on SNAP enrollees. We have data relative to folks who are enrolled in our foster care system, people who are enrolled in our First Steps, our early intervention programs, our WIC programs, our SNAP programs. And we still don't, we are working on it, have a place where we can have a very solid dashboard, right? To look and say how the cabinet's doing, what are our key performance indicators. That just didn't exist for the cabinet. And so to bring that forward and make sure that we're able to take action on the information that we have, that is one of the big challenges internally to the cabinet. Second, I will say this, looking at being able to identify outcomes for individuals based on the services they're provided. I think those are big challenges. I think in Louisville, we're working on some, why can't I remember, but basically a connection across service industries, education, healthcare, that I sat on the board. There's some work going there. We're doing that with our Connect program, where we're trying to connect across categories and providers. I think understanding that information, understanding the impact of various programs on individuals to move them forward, both from a healthcare, behavioral health perspective, as well as then what is cost effective. Those I think are challenges that I don't think we have good answers. United Community, thank you, Tom. Those are pieces that I think we all need to work on. what are those connections across systems that have impact? And I think that is a right, particularly from a data perspective. There are many things that we can do with data that we were unable to do 10 years ago, 5 years ago even, and then moving to the virtual environment through a pandemic. What we have is that information on impact. And so being able to extract from that what are our value-based options, right? And how do we look at things like risk across providers? Those are the things that I think we're going to have continuing discussions about. And again, those are the places that I think we can learn from each other.
Yeah, I think we all learned a lot implementing telehealth, because we all had to move quickly and we had to remove some regulations and put in some kind of temporary processes and procedures around that. One question that's come up a couple of times in various forms is, if one of our companies runs into a barrier for implementing what they believe might be an innovative technology, what's the best way to approach that so that we can have a conversation about how to remove those barriers, whether it's an executive branch decision, a policy decision, or whether it's a legislative play in order to remove what might be perceived as a barrier?
Well, the answer's in the question. If there's a statutory provision that needs to be changed, then it is best to go to the General Assembly and talk to your local legislator about what changes they see and what changes you see that could be beneficial. I would always suggest that you talk to the cabinet because even though we don't have much political capital, we have about that much. But we can certainly support innovation. And then if it's a regulatory piece, that it's either with the cabinet or with public protection, Department of Insurance, or somebody like that, approach that agency. And again, I would say approach with an open mind and a willingness to dialogue. There are always opposing forces within, as you all know, any economy, any economic system is kind of built to stay in stasis, I think. State government is too. And so challenge to that stasis always brings some reaction. So again, being aware that some of these things take that time and take that discussion is critical. But bring those ideas forward. I'm always willing to listen to new ideas and new approaches. I think we're well past time where we need to try some of those. So as you see barriers, helping identify what those barriers are. Somebody I used to work for, and I will say this, used to say, a former secretary, she used to say, you can be right, you can have the solution, but if you can't help me figure out the path to get there, it doesn't matter. So again, we just need to work together to make sure we can identify what those barriers are on the pathway and how, oftentimes incrementally, we can get to our desired outcome and to innovation. Sorry, another long and slightly answer.
We love long answers. I'm going to switch over for a moment. We may come back and revisit some of these topics, but I'd like to switch over for a moment to the long-term care. You had referenced long-term care before. It's clearly a very important sector in Louisville, as arguably the center of the universe for the long-term care industry. So Kylie, I know you put this question in the chat box. So if I don't get this question right, because I'm going to try to shorten it up a little bit, Kylie, please jump in. But there's two questions here. With regard to long-term care, how does the state support our nursing homes who can provide, in many cases, higher acuity care in a more cost-effective way than taking up needed hospital beds? And then I think in response to a statement that you made earlier, can you elaborate on new thought streams to providing care that has been traditionally provided in a long-term care setting? So I'm going to sum this up, and Kylie, feel free to come off mute and jump in. I think the long-term care industry is changing. I think Louisville is leading a lot of that change. And I'm kind of interested in the cabinet's perspective of, how is it changing? How should it change? And should it change at all?
Right. First, in terms of support for long-term care, I know there's some controversy around that, but we've certainly seen some decline in occupancy across the entire sector. We have also, I think we have been pretty effective in providing options for testing, assisting with PPE. So I feel good about Kentucky's response relative to the long-term care industry. I think what it is, though, we're going to have to focus on what can be done. I'll go back to my previous statement, right? You can be right, but if you can't tell me how to get there, then it doesn't matter. We've done a lot of focusing in the past on tort reform that has been struck down by the courts. So let's think of what else we can do. And with that, I say that because when I talked about working outside the walls, what I mean is how the long-term care industry, as well as the facilities, have the experience and knowledge of how to care for individuals who need that care. And where we have a dearth of provision of service is really in the community. We have waiver programs. We're looking at a PACE program, which Kentucky's only 20 years behind. How do we support providers and service providers to provide some of that community-based care? Investment, and I leave this to folks who are much smarter than I am relative to the industry, but investment in brick and mortar. What is that return, and what is that liability? So how do we figure out how do we help in partnership with the long-term care industry to work on liability from a different perspective, to work on liability from how do we have perhaps even and support better trained workforce, more directed workforce, provision of service where you don't have some of the facility style liability that we all have. The cabinet runs facilities as well. I can empathize with workforce challenges, workforce turnover, what that can mean in an enclosed space. Those kinds of things that I think, how do we do that in a way that remains, as we see what we know from a demographic trend is going to be more and more folks entering into the aging population. We're going to see that, but I think it requires different responses. What are to go back to an earlier question, what are the technological innovations of home monitoring and all the different monitoring pieces that we are now coming onto market in ways that are more effective than they have been in the past? So what are those possibilities? I brought on, many of you do know, Keith Knapp, who was over Christian Care Homes, now with University of Kentucky and also with the cabinet. And I brought him on with the specific purpose of taking a look at the long-term care side and having somebody who understands what that means to run a facility, as well as understands the industry. So I brought him on with intention and purpose to have this discussion with somebody that I hope is trusted across the community, to say, how can we move forward in a way that then supports that provision of service in locations and in modes that folks want and will accept. And how do we adapt then our system to do that in a way, again, you've got some economic structural pieces, right? How do we move that in a way that then is supportive to the folks who are within that healthcare and economic sphere, and again, the goal being how do we better support the individuals who need those services? So it's kind of a long way around again, but those are the things that we're trying to look at in terms of how we can be in partnership to make rational changes within our systems that then really support the individuals and the services that those individuals need, again, in the quality and quantity necessary. So I did hear the additional high end of the acuity scale, but we also need to look at the lower end of the acuity scale as well. That's where I think we have a cruel system right now, right? If somebody needs to come into a nursing facility, probably the best way to do that is that they have some kind of acute episode and get into a nursing facility that way. That's the way that most people get into that long-term care side, particularly through Medicaid. That's just a cruel system, and that's the system that we have. We need to work on that. I have a mother that's 91, and I face that today. So how we do that and how we make it less cruel, because that's where we are today. Again, that's that resilience and trauma pillar. I think that relates directly there. But how to do that in a way that's economically feasible and supportable and sustainable, those are the challenges. And I'm not positive we found answers, but I think that may be where we have to look at almost other countries and other modalities. Anyway, another long answer, but I hope that provided a little illumination here.
I've got a question.
I got a question quick, if I could,
go ahead,
just to
Dan.
follow up on some of the modalities. One of the things that I notice, obviously in metropolitan areas, we have great access to communication resources, especially the internet. But I've been traveling more and more in our rural areas in Eastern Kentucky, and we can talk all we want about telehealth, but what I've been told by many providers there is, well, that's fine, but we can't get the telehealth to our patients.
Mhm.
And I'm wondering if you know of initiatives that are bringing the internet to the patients, to the residents, so that they can communicate with the healthcare providers and make telehealth more effective.
That is a great question. So the one huge initiative outside of cabinet, hooray, is the broadband initiative that is trying to bring broadband to rural areas of Kentucky and making sure that that backbone is there so that folks can connect to the high-speed internet that is necessary. So that's a tremendously important economic initiative that then will relate to
Morning.
healthcare. The other piece of that
Let me put
is,
this on mute for a second. Hang on.
the other piece of that is
Just listening on a webinar. What's up?
to address,
You're not on
again,
mute.
from the equity perspective.
Hold
so
on a
that's
second,
rural
everyone.
equity, is
Could we
what
mute?
is, how do we address the digital
We have done
divide?
that
How
in
do
the
we
past.
provide
I have not
services to
wanted to do
individuals
Indeed
and
anymore
those
because
devices
it
to
just brings in
individuals,
so many garbage resumes to come
and
through.
support doing that
So-
will allow them access to telehealth? And then, really kind of making the low impact broadband pieces around around our
Yeah.
phones, right? So that we can provide again those pieces that folks can use, and it's going to have to be simple. I think using the internet is important for our younger
I can see that.
population who can get
on
there.
this one, it might not hurt to
Some
do
of our
Indeed.
older population have
I mean,
very specific
oh.
challenges in using the internet. So it's
Um,
addressing that digital divide, and it's providing the infrastructure, right? And broadband is infrastructure at this point. There is no question about that. Providing that infrastructure so that folks can connect. But that's a long-term play, midterm play, hopefully. But that is then what needs to happen.
Thank you very much. Go ahead, Ben. I didn't mean to cut you.
No, that was great. There was a question about shared savings. Are there opportunities for providers to share in savings when they help avoid costs? For example, if a provider offers a mobile primary care visit to a member who typically requires transportation to access services, then would that provider be eligible to receive a portion of those savings?
Currently, I think that since the majority of those types of services that I think you're describing would go through our MCOs rather than fee for service, I think MCOs are interested in some value-based and risk-sharing opportunities. We're going to continue to try to push that. We started to have that discussion 5 years ago at the end of the Steve Beshear's administration. Many of you participated in a lot of those. with Emily Parento and others on some of those value-based options and working through some of those things. We're going to need to revisit that. It is something that I was hoping to do from the start. Something kind of got in the way, but we are going to go back and look at what some of those opportunities are for us to figure out what those shared savings, shared risks models could be.
Couple other questions. This is not related to anything that we've talked about yet, but has come up a couple of times in various forms. Status of the 115 waiver. I believe this is related to criminal justice and people leaving the criminal justice system and being able to access the system. And I'm assuming this might have something to do with substance use disorders.
It does have to do with substance use and providing some services within correctional facilities prior to release to assure that that individual coming out of a correctional facility has access to behavioral health and substance use support once they make it to the community, again, addressing recidivism. That 1115 waiver is still with the federal government. It's, I think, one of the ones that's been there the longest. We've heard, how to put it, we've received positive feedback, but we haven't received approval yet. So that's the status at this point. We're looking then also, President Stivers is committed to effective substance use services. We are looking along with Secretary Justice Noble on ways that we can look at intervention at a pre-adjudication level. I think some examples, there's a CAHOOTS program in the Northwest. And I think Louisville Metro and I think Northern Kentucky have some models about not necessarily sending, the first responder is not necessarily law enforcement, but should be somebody who is trained in behavioral health and substance use. There are those models that are all across the country. What we're trying to do in Medicaid is then examine maybe how we marry that style of model to community health workers and peer support. And what would that look like if we had, again, a functioning model in that way? We're at the front end of that discussion, but it is something that is occurring.
A couple of pandemic-related questions or COVID-related questions. I'll start with the first. There's a few providers on the line that are asking about vaccine hesitancy, resources, awareness. What can we be doing to increase, what kind of information does the cabinet have, or can the cabinet connect providers to that will help increase vaccine acceptance in the community?
So I hope you all have seen some of the advertising and marketing that we're trying to do across the Commonwealth. There are resources at our kycovid19.ky.gov website. Please go there. There are communication packets. There's information and material there. Please use them. But the most important thing is to use your agency and to use your leadership both in the community and with folks that perhaps some of you serve to provide that example, right? I'm fully vaccinated. My mother, 91 years old, is fully vaccinated. You can use the examples of, you can see this just, once we were able to get vaccinations within long-term care facilities, those rates just fell off a cliff. It's a shame we don't have more staff who've decided to get vaccinated, but we're continuing to work on that. And it's the individual stories. Our mass vaccination sites are, and this is true across the country, but are really starting to fall off. That's not the answer right now. The answer is the ground game. The answer is individual providers. The answer is employers asking, requesting, cajoling, incentivizing their workers to get vaccinated. We will, if folks making requests, we have some mobile capabilities and some of our partners, particularly local health departments, some of the FQHCs have opportunities to provide some of these outreach clinics. We're into the ground game now. We're going to have to do these pop-up events. we're going to have to get into communities, and we're going to have to communicate to individuals with stories of folks who've had COVID, and that it is very serious. We've got to counter what I think is a massive disinformation that is out there. The effectiveness and safety of the vaccines. There's no microchip, right? I'm that level of disconnect from I don't know how to say it, reality. How do you get through that? And I think it has to be then a one-on-one conversation, micro-targeting communities, and then really providing the examples of you really don't want COVID. We now think studies are showing that a third of those people who have contacted COVID are what are called long haulers, who have symptoms for months. And again, we're going to look at the impact of COVID as a vascular disease. We're going to be looking at the impact of COVID for the next 20 years. Again, talking about long-term care, what's that going to do to the percent of population that are going to need more extensive services over a longer period of time, more chronic than acute. And we're beginning to see that. I think all of those pieces are going to need to be brought into play as we discuss how important it is for folks to get vaccinated. And the quicker people want to do away with these, right, the more folks are going to need to get vaccinated more quickly.
I think it kind of as a follow-up to that, and I know that we're nearing time, but as a follow-up to that, we started part of today's conversation with the idea of fully open and what does fully open really mean. So I'd like to hear from you just a little bit more about what you see as fully open means. And then the idea, some states have announced a firm date in which we will be fully open. Kentucky has put it on number of people with an immunization. Can you talk a little bit about, from the healthcare perspective side, of the pros and the cons of drawing a line in the sand in a date versus number of vaccines, and giving people hope that we're going to return to some semblance of normalcy?
So I think the governor has talked about some willingness to look at what an accelerated time frame might be. So I think that's out there in terms of that discussion. But so what does return to normal mean? I think as we get more and more folks vaccinated, return to normal is return to normal is return to new normal. And some of that is going to really be dependent upon what happens with COVID-19, what happens with variants, what happens with the continuing effectiveness of vaccinations against variants, and what does that look like? And I can't predict that. And so that's just being honest. Second is, though, what is that new normal? Certainly it's returning to open restaurants and returning to open outdoor events. But hopefully it is with an understanding, one of how important and vital those events and those times with loved ones are, and that we all gain a deeper appreciation of what that is. I will say, non-COVID, we haven't had a flu season this year. Is it because we've been better about wearing masks? And what does that look like moving forward? Is it that we've learned that, for the men out there, that we need to be much more careful about washing our hands and what that personal hygiene is? If we can carry that forward, that's going to have an impact across all of healthcare. I hope that we do that. So that new normal, I think, is coming. As you can look at many other states, I think it's coming. But when, and then how do we treat each other once we get back there? And what have we learned from going through this? I think those are going to be important lessons carried forward. Like I say, if we can just carry forward some of the personal hygiene pieces, we are going to be a healthier population. as simple as that is, but it's always sometimes the most simple things that have such great impact.
Well, thank you. We're at time today, and I want to be respectful of your time. I really appreciate you coming out. So I'm going to toss it back to Dan. Otherwise, we'd probably sit here for another hour and a half talking about.
This is a great conversation. I do appreciate the opportunity.
And I will say before I hand it off to Dan, the Health Enterprise Network represents, the business of healthcare in the region. And, I think one of the things that we want to make sure that this organization is doing, and all the people on this call are starting to build the relationship so that we're having more frequent conversations like this, so that when we do run into barriers, or when we run into opportunities for collaboration or challenging the way things are done, we can have that honest dialogue and work together to build a better healthcare system rather than in an adversarial type of way. So with that, Dan, I'm going to hand it back to you, and you can send us all on our merry way.
Well, I don't want to hold up everyone. Thank you again, Secretary Friedlander. This has been very, very informative, and I think we could talk all day. One area that I think you've invited is more thoughts of how we can help collaborate with you to provide better healthcare to the entire community. And we didn't even get into the topic of private-public partnerships and where that may exist, and how we can expand the otherwise limited resources that are available to you to do everything. So, and that's with the legislator, I think, and others. But thank you very much. It's been a very engaging conversation. To all our guests, we really thank you. This has been an outstanding attended event, probably our largest. And that indicates to us there is great interest in these forums, and hearing from your not only elected officials, but officials who have been appointed to help us with our healthcare and other government services. So please, this is the forum where we can engage with Secretary Friedlander and others like his peers, and we can make a difference. This is what the Healthcare Forum is all about. And I think that we've learned ourselves that having a virtual option is better than in person, or having both. We're continuing to study that, but I think we expand our population by having this option available. We invite everyone to join the Healthcare Forum, to become a member, to provide your input into future content. And with that, I want to wish everyone a very, great rest of your day, a great spring, enjoy the weather, and get vaccinated. I'll throw it out there. That'll be my first. If anyone isn't, I'm fully vaccinated. So anyway, thank you all, and have a wonderful day.